Hello, my name is Samantha Trench. The title of my doctoral capstone project is the Disorders of Consciousness Scale Clinician Training Resource, completed alongside site mentors Kai Atkinson and Alex Wax at Shirley Ryan Ability Lab, with assistance from faculty mentor Dr. Kelsey Peter and doctoral capstone coordinator Dr. Christine Kroll. A little bit about my site. It's located in Chicago, Illinois. It's an interdisciplinary inpatient rehabilitation hospital. I was located on the Brain Innovation Center, floor 25, where we see patients with traumatic brain injury, acquired brain injury, and also disorders of consciousness. These patients receive services like occupational therapy, physical therapy, speech language pathology, nursing, and medical services. The Amicus program on the 25th floor is intended for patients with formal diagnosis of traumatic or acquired brain injury in tandem with a disorders of consciousness diagnosis. And that includes being in a minimally conscious state or in a vegetative state or unresponsive wakefulness state, but also medically stable to receive intense inpatient rehabilitation services. The primary goal of this program is to determine the patient's precise level of consciousness and responsiveness, advise on medical stability for continued care, optimize his or her medication regimen, trial treatments including physical rehabilitation, sensory stimulation, pharmacological and non-pharmacological neuromodulation, ensure he or she is provided with proper medical equipment, and educate patient, family, and caregivers about their loved one. The needs assessment performed identified primary stakeholders as occupational therapists on the 25th floor, secondary stakeholders as patients with brain injury at Shirley Ryan Ability Lab participating in the Amicus program. I also was able to identify the need for advancement of evidence-based practices by developing a clinician training resource on the revised DOCS 25 neurobehavioral assessment. The need for the clinician training resource came about after meeting with site mentors and finding out more about how the floor relies on peer-to-peer mentorship in order to teach this assessment and how much benefit they would receive from something more official like a clinician training resource on the DOCS 25 assessment. From the literature review, I found that the DOCS test itself was designed to allow the clinician to examine unconsciousness as a continuum of fluctuating levels of neurobehavioral integrity while distinguishing between true change and random fluctuation. It takes about 40 to 60 minutes to administer and can be done at bedside with the person in their environment following testing instructions to apply stimuli multiple times to allow patients their best opportunity to demonstrate their optimal capability. The individual responses are scored on a 3-point rating scale, 0 being no response, 1 generalized response, and 2 a localized response. The revised DOCS purpose, it can be completed at bedside. It's sensitive to subtle changes in neurobehavioral functioning, produces a reliable and valid measure of neurobehavioral functioning. It can identify factors that influence and predict recovery, as well as guide and evaluate the effectiveness of rehabilitation intervention. So the DOCS assessment description, so it can be completed at bedside and assesses the neurobehavioral responses of patients with disorders of consciousness. It's a 25-item assessment organized into 4 sensory domains, and it provides a clear picture of levels of neurobehavioral integrity and quality of behavioral responses to test stimuli across the continuum of coma recovery. So just for some more background, I'm going to give an example of something we'd administer from each domain because it's very interesting if you haven't encountered this before. So for gustation, we would do something like looking for response for the difference between a sweet taste and a sour taste. So this looks like applying sugar to the lips and gums, waiting 15 to 20 seconds, and then applying sour So an example of a localized response would be a facial expression of like, ooh, this is sour, puckering, or a swallow. For the somatosensory section, this could be something like applying vibration to the big toe or an ice cube to the big toe. You see that specific limb moving, you see the toe move, or trying to get away from the stimulus would be a localized response. For vision, we do things like tracking of a familiar face or tracking for an object, and we measure this in the upper, lower, left, and right visual fields. And for auditory language, this would be something like calling the patient's name from various locations in the room. This assessment captures the best response rather than the most consistent response of the patient, provides multiple opportunities to respond to stimuli, and provides multiple response modes, such as verbal, gestural, visual. We use yes, no cards in this assessment. So why is this important? So multiple stimuli and accepted response models helps to prevent misinterpretation of degree of consciousness with consideration of impairments in language, arousal, wakefulness, or awareness. Important components of the DOCS clinician training resource include the clarification of administration instructions of the DOCS assessment through means of video training, interpretation of the DOCS scoring and tracking patient progress over time, and lastly, we have goal writing based on the DOCS assessment. The theory used to develop this project was the Canadian model of occupational performance and engagement, with a background in person, environment, and occupation, all centered around the human spirit. This coincides with the project's purpose in that it provides OTs with the training on the best practice of the DOC assessment with the patient's personal, environmental, and occupational need components to improve occupational engagement and performance. The frame of reference used to guide this project was Toplia's dynamic interactional frame. So this is based in neuroscientific concepts around self-awareness. Colin Tefano states that performance in occupations is based in the ability to perceive and evaluate incoming information and the ability to conceive of, plan, and execute purposeful activity. This coincides with the project's purpose in that the understanding of the individual aspects of DOC patients' person, activities they participate in, and their environment will support the use of the revised DOCS assessment for the Amicus program. So project development began with the literature review of occupational therapy's role in disorders of consciousness patient care, followed by a needs assessment of the therapist on the 25th floor at Shirley Ryan, conduction of a pre-survey questionnaire and observation of clinicians utilizing the DOCS assessment, developing the DOCS clinician training resource, and then implementing this by presentation in a PowerPoint format with the video training with the therapist from the 25th floor, followed by a post-survey questionnaire and observation of clinicians utilizing the DOCS assessment. From the survey and questionnaire I conducted to assess my outcomes of the effectiveness of my project comes the question, did you feel you needed more training on the DOCS neurobehavioral assessment? In the pre-survey, 33% of therapists that work on the 25 floor stated, yes, I feel like I needed more training. After the implementation of the project, 20% said in the post-survey that they felt that they needed more training. I also found that a lot of this came with the fact that therapists believed that they needed mentorship along with the video training and less about the videos not being enough themselves. They feel like the hands-on experience is one of the major components of conducting and learning to conduct this type of assessment with patients. Another question I utilized in my pre-survey and post-survey to assess the outcomes of my project was how comfortable are you in administering the DOCS assessment? In the pre-survey, 33% said very comfortable, 33% said comfortable, 16.67% said neutral, and 16.67 were very uncomfortable. So after the implementation and video training conducted with the project, a post survey indicated that 60% felt very comfortable and 40% felt comfortable, meaning 0% chose neutral and 0% chose uncomfortable and 0% chose very uncomfortable. So I think this is a good visual representation of the effectiveness of the project itself in training clinicians on the 25th floor on the DOCS assessment and the way that impacted their comfortability. The last question I utilized in my questionnaire was, what are your overall thoughts on the training you received on the DOCS 25 assessment? So initially, before project implementation, common themes were that it was detailed, interest in consistency, several on peer support, some questions on scoring, also another theme for consistency. So after implementing the projects, the post survey indicated themes around consistency again, therapist learning, and just overall positive feelings around having another resource to add to the training. To summarize, it can be difficult to estimate rehabilitation prognosis due to the fluctuation of patients with disorders of consciousness. OT's role is to articulate and reliably assess each patient with disorders of consciousness to improve their occupational performance and participation in ADLs and IADLs. Important results from the pre-survey and post-survey analysis showed that the training resource itself improved clinician understanding of administration and scoring, increased comfortability in administration, and decreased clinician perceived need for further training after viewing. So the use of the DOCS assessment allows us to better track patient physical and rehabilitation progress. I wanted to also hit on their physical or medical progress. For example, if someone is starting a new medication and somehow we find that their DOCS score is impacted, we can maybe bring this up in an interdisciplinary or an interprofessional communication saying, hey, something's different. We're noticing this, this, and this, because it's a very in-depth assessment that gives you a good idea of their overall responsiveness to stimuli. And that coincides with the interprofessional communication, as well as I want to talk about communication with family members. Part of the revised version of the DOCS assessment gives us a nice graph to where we can plot points and show family members, like a physical or visual representation of how their loved one is kind of recovering or what their rehabilitation scores look like, and give us a point to kind of explain further on. I thought it was important to create this new clinical training resource because Shirley Ryan is founded upon evidence-based practices. And when new evidence comes out, it's important to get that to therapists and help to close that gap between literature to practice. This also has implications for neurological rehabilitation of pediatric DOC patients. We find that it's developmentally appropriate to administer this to preschool age children who can follow the one-step commands required in the assessment. So this clinician training resource will also be distributed to the 18th floor of inpatient pediatric rehabilitation at Shirley Ryan Ability Lab and is the first training resource for them on this assessment. These are my references, and I want to take a moment to thank you for viewing this presentation and give a thank you to everyone who helped me on this journey. It's been a wonderful experience. Thank you. I would also like to give my acknowledgments here at the end after references. First is to Dr. Teresa Pape, listed several times here in the references, is a speech language pathologist out of Northwestern, and she works with the VA as well. She is the developer of this clinical assessment tool, and it's just wonderful to have something so specific for this patient population to give us all a better understanding of coma recovery continuum. So a thank you to her. Thank you to my site mentors who facilitated this project, as well as all my many experiences at Shirley Ryan. It was absolutely wonderful to work with you. And of course, to my patients, your caregivers, the family members, it was absolutely an honor to work with you, and I'll never forget you or this experience that we've had together. And to those of you who watched and listened to this voice thread, I appreciate your time and willingness to want to learn more about coma recovery and how the occupational therapy profession impacts this. So, thank you so much.